Well, welcome, everyone. Appreciate you joining us tonight. We'll make it a few more people in a little later. I know it's AIA week, but this was a target of opportunity, as we say in the Army. So I want to appreciate Dr. Pruitt for taking time out of his busy schedule. We've talked with him a number of times here, and I know he has a busy schedule, and certainly appreciate that information. This is an effort to see if we can generate some interest in some issues. This may be a first of many on this subject, if there's an interest. And I appreciate Steve for chasing this, and he's kind of been an effort on his part to bring this to fruition. So Steve, without further ado, I pass it to you.
Sure, thank you. Steve Chamberlain here, one of the co-chairs. I know we've got a small group, so I really encourage those who are here today. And as Harold said, it's a busy week for MOAA, so hopefully on our next session we'll get a few more folks. But definitely tell folks about it. This will be the first of what we hope is a several session series where we're discussing veteran suicide prevention programs, what you can do at the state level. This first session is not intended to get into the real micro specifics of various programs, although feel free to ask some questions. If questions pop up, we'll make sure we have plenty of time for that. What we asked Dr. Pruitt to do today is provide a very high level look. Dr. Pruitt, actually, let me give you his background first so you know where he's coming from. He's the director of suicide prevention at VA Puget Sound in Washington State, which consists of 2 large medical centers and 7 smaller VA community clinics. If I got your details correct, you've got a team of 12 clinicians who provide local response to crisis call from the National Veterans Crisis Line. You identify and facilitate healthcare for vets who are at risk of suicide and build connections, resources, and agencies in the local community to share a commitment of wellness for our veterans. And Dr. Pruitt holds an associate professor position at the University of Washington School of Medicine's Department of Psychiatry and Behavioral Sciences, has published a lot. Needless to say, he's an expert on veteran suicide prevention. We don't need to go line by line through the VA's recent report. What we really want to do here is talk in very general terms about what that report says between the lines, what Dr. Pruitt is seeing in terms of effective approaches in a very general way, kind of the 30,000 foot view, and what approaches have proven to be less efficacious, less effective. And the whole idea for tonight is to kind of seed your minds with things you can do at the state level that will be effective, and avoid going down paths to different approaches that perhaps have been proven to be less effective. And as we have subsequent sessions, we hope to really delve into some of those really effective or promising or on the horizon approaches. And those are the things we want to talk about tonight, but like I said, in a very general way. So with that, Dr. Pruitt, I will hand it over to you, and Harold will work the slides for you.
Great. Thanks so much for that intro. I really, I enjoy discussion around this topic, so feel free to interrupt me at any time with questions. We'll definitely have some time at the end for those as well. I wanted to start by really just taking a moment to acknowledge that this is a difficult topic. We're talking about people's lives, and I want to respect that. So as I'm talking through the numbers or interventions or theory, I may not focus specifically on the individual, but I want you to know that I always try to never lose sight of those individuals as the motivation for doing this work on an ongoing basis. And so, as you'll see from the slide that's up, I'm going to use a little bit of juxtaposition to bring this issue into focus, hopefully a little bit of humor. That's not because I don't think this is a serious topic or it doesn't warrant high level of focus. It's just that we need to be able to frame this in a way that allows us to see that it's not simply the emotions that drive this, that there's science behind it, and we want to pay attention to that. Okay, so you see here on my intro slide that we're gonna, at least at the start here, talk about suicide prevention having a Bigfoot problem, or another way to look at this is suicide prevention and Bigfoot having a lot in common. Harold, if we can go to the next slide. Okay, so what you're seeing here is a map of the state of Oregon. There are neighbors to the south, so I get to poke fun at them from time to time. And on this map, and you can find this if you go to Oregon, they have these out and around, and you can find them. And this is a map of Bigfoot sightings, sounds, footprints. And in a lot of ways, this is like suicide prevention, right? There's a lot of signal-like information on this map. There's certainly a lot of noise. But the one thing, if you look over this, that you won't find are true signals. They won't find the location where Bigfoot was actually found. There's no conclusive evidence to suggest that that is valid. And so if we go to the next slide, and this is my last one, I'll have you play a little game of fill in the blank here. And I made it easy. There's only two choices. You can fill in the answers here with Bigfoot sightings, or you can fill in the answers with suicide prevention. And I would ask you to take a moment and read each of these statements and choose, what I'm talking about here. Am I talking about Bigfoot, or am I talking about suicide prevention? And for the sake of time, we'll go to the next and final slide, which just gives you the answers. We've heard about a program that just makes too much sense. But at the same time, we don't really have that conclusive evidence to say, hey, this is the thing that will work. Okay. So this is relevant because all suicide prevention interventions, whether it's universal screening or predictive analytics or peer support or resiliency training, are kind of like this map of Oregon, because we don't have that real thing to point to and say, this is it. We haven't captured it yet, despite lots of people putting forward lots of ideas and lower levels of evidence around different things like the sights or sounds. Okay, so you can drop the slides for now. As we get into this, some people might argue that the reason we don't have that magic thing yet is because the right kind of study hasn't been done. And that's certainly possible, though in the military and veteran community, these interventions have been packaged up and deployed comprehensively across the service member and veteran population. And if one of these things was going to be the thing to reduce suicide, or a combination of things to reduce suicide, the rates that we see from year to year over the last 25 years wouldn't be still going in the upward direction that they are. Now, I want to be clear that this is not a military, military and veteran population problem alone. The number of suicides in the US population has increased by 61% in US adults from 2001 to 2023, and up 75% in the non-veteran population. So from about 23,559 in 2001 to over 41,000 in 2023. Meanwhile, amongst veterans, that increase in the count has gone up only 6%, from 6,021 up to 6,398. Now, why the military and veteran community stands out so frequently is not because of the numbers, it's because of the rate. And we'll talk about rates here. Rates are embedded in the size of the overall population. So, and I'm almost done with numbers, I promise. In 2001, the non-veteran population had a rate of 12.6 suicide deaths per 100,000 members of the population, whereas the veteran population had a rate of 17.1 per 100,000 members of the veteran population. That's only about 4.5 different points different in those rates, which is, a difference. It's measurable, but it's not huge. Now, fast forward to 2023, the non-veteran population is essentially where the veteran population was 25 years ago, and it's currently at that 17.1 number, whereas the veteran population has increased all the way up to 35.2. So now instead of a 4.5-point difference, there's an 18-point difference. 18 deaths per 100,000, so a 13.5 point difference between those two populations. So when we look at the veteran population, not only has the rate doubled, but it's increasing faster than those other sectors. And that's why we really have a lot of concern when it comes to the military and veteran population. I'm going to talk about why that's concerning here in a moment, but first I'm going to go on a little bit of a tangent just for a moment and talk about the language, because this is actually important in how we frame suicide overall. One thing you won't hear me say in this talk is the word commit, as in veterans that commit suicide. This is because the only medical condition where we use that language is suicide. It's somehow become unique, but it's not accurate. It denotes in some way that the act of killing oneself is volitional, when in fact it's not. It's important to consider that suicide has been a top 10 cause of death for much of the last 25 years, but so have things like heart disease and cancer. And like heart disease and cancer, there are behavioral and there are biological components that underlie all of those. To make it a little bit more concrete, you would be hard-pressed to find pretty much anybody, certainly a medical professional in today's world, that wouldn't tell you that smoking cigarettes, for example, contributes to both heart disease and cancer. There's a behavioral component to that. There's a biological component to that. But other factors are things like genetics and medical history and environment. And all of these things are true of suicide as well. It's a complex interaction of one's history, their environment, their biology, and their genetics. But we don't say that somebody committed heart disease or somebody committed cancer, even though there are biological and behavioral causes for all of those. We say that they died by heart disease or they died by cancer. So when you hear me talk about suicide, you'll hear me say the term veterans who die by suicide or died by suicide. And by using that same language that we use with other diseases when we categorize suicide, we put it in the same group, the same box as those other biological and behavioral conditions. And when we group them together by using the same language, we don't stigmatize the thing that's different. Rather, we treat them all as problems to be solved. Okay, so I'm going to get off my soapbox here and get back to why veteran suicide rates are increasing faster than in the veteran population. So suicide is often the result of a complex interaction of risk factors and protective factors at the individual, community, and societal levels. Risk factors are those characteristics that are associated with an increase in suicidality or increase in suicidal behaviors. And protective factors are those things that help offset or minimize suicide risk. So to prevent veteran suicide, we have to maximize protective factors while minimizing risk factors at all levels. And we have to do that throughout the community, which is no small undertaking. There is one longstanding and kind of well-accepted theory, which I like to think of as almost an algebra problem. So this is from Thomas Joyner, who's a professor down in Florida. And you can think of this as x plus y equals z, where z is death by suicide. And in this equation, x, that first condition, is something called thwarted belongingness and perceived burdensomeness, okay? These are two factors that have to be present for somebody to start thinking about suicide. And thwarted belongingness is a perceived loss of connection with one's social group, or not being able to really join or participate in a social group. So you can think of somebody who's isolated or ostracized or just can't join in with their community, okay? The other half of that is perceived burdensomeness, right? So maybe you don't have that problem, but you don't feel like you're giving anything back to your social group. You feel like you're a burden or that you're costing your group more than you're giving to them, okay? Those social conditions are the impetus or the required conditions for suicidal thinking to occur. But that's not enough to produce suicide behavior, okay? So for thinking to turn into behavior, you have to have the second condition, that Y value in the equation. And that's something called acquired capability, okay? Now, acquired capability is the desensitization of an individual's natural aversion to death, dying, and injury. We are all born with innate drives, right? The desire to eat and sleep and socialize, and to avoid pain. That's why if you've ever seen a kid sort of touch something that's hot, they'd never do it again, because we are conditioned, we are built in a way to learn from those and modify our behavior as a result of it. And sometimes we use that to the advantage in psychotherapy. If we're dealing with an individual who is suffering from a phobia or even post-traumatic stress disorder, we capitalize on this desensitization process to wear the fear out so that they can do the thing that they're avoiding, right? Well, that can happen naturally as well. And for folks that have been around a lot of death, dying, or injury, it wears down that natural aversion, right? That natural avoidance of morose and gory details. That's why you see high rates of suicide amongst emergency room physicians and dentists and first responders, right? Because they're around that stuff a lot. It also explains why we see high rates of suicide amongst our veteran and military members, because they also are exposed to those things at a higher rate than the general population. So when you have the conditions that lead to suicidal thinking and you have the experience that can make the action associated with those thoughts happen, then you run the risk of somebody really being at a high likelihood of dying by suicide. Okay. Now, if you've been around long enough, you can probably point to cases that don't fit that model exactly right? Somebody who is well connected, who has a strong peer network, who has lots of reasons for living, and they still die by suicide. And that's completely valid. And what I would tell you about that is, just like we have different subtypes of cancer, those cancers have different causes, different courses of the disease, and different cures. And the same is true for suicide. Though we tend to talk about suicide as a single thing, in fact, it's far more complex. And the factors that put a 32-year-old at risk, typically things like a problem in their relationship or ongoing mental health issues, are going to be very different than the risk factors for a 55-year-old who's dealing with threats to the stability in their work or their lifestyle, changes in finances, maybe career issues. And that person is going to be very different than a 77-year-old who might be dealing with the loss of independence, medical issues that are cropping up, end-of-life issues possibly. And the reasons that those might translate into suicidality are going to be as different as those individuals are. Okay. Now, those are all external characteristics to some degree. But even if we look at more internal factors, there are some subtypes of suicide that are emerging, each with different interventions that are indicated for them. The first of these is sort of the impulsive, or what we would call emotionally dysregulated individual, somebody who really doesn't have the ability to cope with the stressors that are happening in their life. And for them, the indicated intervention is really building skills, right? Giving them those coping strategies, those tools to use when they're confronted with an overwhelming situation. The next type is what we call internalizing, or classically sort of depressed, but it can be more than just depression. It can be anxiety as well. And in those folks, really what we're focusing on is treating the underlying condition, right? Treating the anxiety or the depression or the PTSD. And by doing that, you remove that focus on suicide, sometimes because that becomes the only way that they can see of coping with that condition long term. The third one is what we call dependent or contingency-based suicide. Oftentimes, these are folks who say, well, when this happens, or if this doesn't happen, then I'm going to die by suicide, right? When I turn 40, or when I turn 60, or when I retire, or if my wife doesn't take me back, whatever it might be. Those individuals really benefit much more from problem solving, right? Thinking through, what do you have to do to make yourself get to that point where you're going to be okay? And something called behavioral activation, right? Which is getting out, engaging in your life, doing the things that maybe you've stopped doing because they're overwhelming, and connecting with the natural benefits that happen when we live a purposeful and meaningful life. The fourth one is hostile or isolated. And here we're talking about really, it's building that community that I mentioned earlier, building in a sense of meaning and purpose and connection to others. And you'll see that that resolves a lot of that hostility and isolation that then also drives down their suicidality. And the last one, I don't love this term. It's called psychopathic. Really, it might be better termed as psychotic, as in the other psychotic disorders, things like schizophrenia, and other sort of features where there's problems connecting with reality. And in that, those deep ingrained organic mental illness characteristics just carry with them an extremely high possibility of suicide-related risk. If you're hearing voices that are commanding you, telling you to harm yourself, it's very, very draining, one, and difficult to separate those from reality, right? And so until you get on the right treatment regimen for those, that can be a really risky period. That's going to be very different than those other 4 groups that we talked about, right? So with those different causes, there's different interventions. And that's why there really is no one-size-fits-all approach for suicide. Now, you might be asking yourself, why hasn't this understanding of these subtypes of suicide led to success in driving down the suicide rates? Well, the problem is we tend to approach suicide and suicide events as the primary target for intervention, right? And we try to prevent a crisis from happening, and we don't do so well at preventing the things that led to that crisis in the first place. When a crisis is happening, it's already too late in a sense. Everything that got that person to that point is done and in the past, and we can't change that. But if we can work upstream ahead of those things developing, then we have a much better chance of averting that crisis. And so rather than targeting sort of that process, that outcome that happens, we want to target the process that leads into a crisis. This is sort of like, and I keep going back to these medical analogies, but I think this works. It's sort of like targeting the damage done to one's body when you have a heart attack by taking a baby aspirin, right? That's a life-saving intervention in a crisis moment that should be done, right? But there's also plenty of things that could have been done well ahead of that time to reduce the likelihood of heart disease happening in the first place. And so suicide is an outcome of a pathogenic mental health process in the same way that a heart attack is the outcome of a pathogenic cardiovascular process. There are 2 sort of parallel things happening as a result of a long string of, again, biology and behavior. If we get hyper-focused on preventing the suicide crisis and neglecting the process that led to that crisis, that might involve things like depression and anxiety and substance use, or neurocognitive disorders, or trauma exposure, social isolation, desensitization to death and dying, all of these things that we've talked about, then we get stuck trying to manage a crisis that's already happening. And this is kind of in the same vein as focusing solely on perfecting the perfect bypass surgery that neglects the role of diet and exercise and genetics when we're talking about heart disease. If we don't address diet and exercise, then we're not really reducing the rate of heart attacks. We might improve the survival by having that perfect bypass surgery in place or that perfect crisis intervention, but we haven't addressed the root cause. So similarly with suicide, without effective treatments for depression or anxiety or trauma, we haven't really addressed the root cause for suicide. And instead, we're left treating the symptoms rather than the causes. What we need to find is a strategy that focuses more on treating those causal factors that lead to suicide down the road and do that as early as possible than it is having the perfect response for that crisis when it's already occurring. Just to continue the heart disease analogy for a moment longer, what I'm talking about would be more akin to finding ways to promote exercise and better dietary choices rather than ensuring that we have that perfect bypass surgery to treat a heart attack that's already happened. So you can think of this as in a perfect world scenario, we would have a 3-fold approach, right? So approach number 1 would be the far upstream prevention strategies at the public health level to ensure that the issues that lead crises, suicide-related crises, to develop are addressed as early as possible at the lowest level possible. Then, for those for which that wasn't effective, you'd have these second-level strategies that are more in the interim, right? These are the treatments for those co-occurring conditions like depression and anxiety that can lead to suicide down the road. But if we can treat them effectively up front, that's not going to turn into that crisis outcome. And for those folks that don't respond to that level of intervention, the third step would really be having the crisis intervention, that final safety net in place to divert cases that have made it through the other two barriers, so that we can mitigate suicide risk in the moment by modifying the environment that somebody's in or giving them those coping skills at the end. Okay. So there's lots of routes here into a suicide-related crisis and no exact clear path out of that crisis. So what does work? Well, some of the best evidence to date are population-level interventions, right? Lethal means safety is one that I talk about a lot because it has some of the best evidence for across the board, okay? Lethal means safety is a kind of a technical term that can be boiled down to simply adding time and space between an individual and their planned method of suicide, okay? There's lots of strong population-based evidence for this. So if you spent any time on the West Coast, you may have seen the Golden Gate Bridge, the Coronado Bridge in San Diego, or the Aurora Bridge here in Seattle. And those three bridges were selected because they were considered suicide hotspots, because a lot of folks died by suicide at those sites. To participate in a program where bridge nets or fences were put up that prevented somebody from falling over the edge, or if they did, getting caught before they fell too far. What they found as a result of those structural interventions was an 85% reduction of suicides at those sites. And almost more importantly, there was not an increase in other methods of suicide later on. That 85% reduction carried forward without any increase in other methods of suicide in the surrounding areas. Okay. Another similar analogy is think of the cooking stoves that your grandmothers had, those kind of old cast iron coal burning stoves, right? And the anecdotal story of the housewife sticking her head in the oven and dying by suicide comes from that as an actual method of suicide in England, 100 years ago. And what would happen is when you burn coal gas as a fuel source, it gives off a lot of carbon monoxide, and that would accumulate in that oven chamber and sit there. And so when England switched from coal gas to natural gas, which only gives off about 1% carbon monoxide, that no longer was a viable method for suicide. And although folks still did that or still attempted suicide in that manner, it wasn't effective. And similarly to the bridges that I mentioned, what you found was a reduction of suicide by that method and no increase in other methods of suicide. There's two other really good examples of this. The first comes from Sri Lanka, and these are, again, national examples. In Sri Lanka, the number one cause of death for a long, long time by suicide was the ingestion of pesticides, okay? And in particular, I'm going to probably stumble over this, but two chemicals called parathion and methylparathion, which are organophosphates, right? Suffice to say, toxic chemicals that were used in their farming industry. Now, in 1984, they banned one of those two chemicals, and there was no change in death by suicide. But when both chemicals were banned in 1995 at the national level, there was a dramatic reduction, almost a halving of their suicide rate, and no increase in other methods of suicide. And that continued on from 1995 forward. The last example I'll give you comes from the Israeli Defense Force, and they required their service member and military members to turn in their firearms during periods of leave and weekends. And when they did that, they found a 40% total decrease in suicide rates. Again, no increase in other methods, and a 70% decrease in suicide rates during the weekends when folks were away from their duty stations, okay? So lots and lots of evidence here done at the national level, looking at lethal means safety and finding pretty dramatic beneficial effects. Now, in addition to lethal means safety, there have been a couple of other international studies that have been shown to substantially reduce and decrease the rate of suicide outside of the US. We haven't seen that happen here yet. So for example, in Japan, which had some of the world's highest suicide rates up into the end of the 20th century, they found that by implementing a national program in 2009 that they were able to drop their suicide rate from 25.7 per 100,000 to about 16.5 per 100,000 by 2018, so in just 9 years. And they did this through heavy investment in something they called the Emergency Fund to Enhance Community-Based Suicide Countermeasures. That's a lot of words to say that the intervention focused on a system for the early detection of suicide risks, so some surveillance, and then targeted medical service delivery to those individuals who are identified at high risk. And for anybody who engaged in suicide-related behavior, there was sort of mandatory mental health support, not only for the suicide attempt survivor, but for the families of individuals who lost a loved one to suicide. And this was done by federal funding of regional or prefectures or states based programs based on the local culture and the customs of those regions, but in a way that was consistent with the overall empirical or scientific evidence. So they said, hey, here's a structure, but we want you to customize that public health structure within what's going to make sense for your particular region or area so that you have buy-in from your local population. And while that international approach may not be completely generalizable, it does provide sort of a handy roadmap for creating population level changes here in suicide prevention. So for example, if that intervention from Japan sounds familiar at all, it may be because the VA and SAMHSA over the last decade or so have been rolling out a similar model, right? Minus the federal funding, but something called the Mayor and Governor's Challenges for Suicide Prevention for service members, veterans, and their families. And currently, all 50 states, as well as all US territories, have an ongoing Governor's Challenge focused on reducing suicide within that specific state. And it doesn't matter if it's Texas or Rhode Island or American Samoa, they are looking at within the local community, how do we prioritize reducing veteran suicide? For you all, and in particular for this group, which has a legislative component, I would encourage you to reach out to your Governor's Challenge team and find out what efforts are underway. Oftentimes, these are happening without legislative champions. And when that occurs, there's a lot of good ideas that get stood up, and then they simply kind of go away after time because there's no one to sort of codify that into legislation. So as folks change jobs or positions or move on, those things kind of lose steam a little bit. But in states where there is legislative involvement, those really positive programs tend to get written into law or supported in some way and stick around for longer term where we can look at the effects of those interventions. In addition to legislative support, one of the other things that's needed to put this into place is collaboration across national agencies, state healthcare systems, especially large healthcare systems like the VA, to standardize our approaches and procedures and methodologies and how we measure suicide. We need to have adaptive interventions that can pivot based on the presentation of the individual, based on those subtypes like I mentioned earlier, rather than using a one-size-fits-all approach and having a structure that allows that to happen on a large scale. We also need to improve care coordination so that as our veterans are transitioning out of the military or into VA care or through a phase of life like retirement, that happens seamlessly and with support of the structure that they're going into or the structure that they're leaving. We know that veterans go through a lot of transitions, right? Civilian to service, changes in duty stations, deployments, exiting the service, starting life as a veteran, changes in jobs, changes in family, and that problems crop up as that transition between stages happens over and over again. And so we need to ensure that they're supported during these transitional period because transitions are a particularly risky time for individuals. I would point you all to look at a program called Onward Ops. This is a nonprofit program that aims to ease the 3 times increase in suicide risk that happens as a service member exits the military. They work to connect veterans to veteran sponsors, folks who have lived that transition and settled and did it successfully, who are living and working in that veteran's local community where they're planning to go after their military service. And they serve as a mentor for those folks as they move into civilian life. And they do it in a way where the local community is a partner and making sure that that person's needs are attended to, that they know where the school is and where the places to live are and where the jobs are and all of those things that the person might have been struggling to do on their own. They also coordinate and ensure that the veteran is connected to their benefits and the healthcare that they've earned through their service. Okay, so thinking back to Joiner's model, what's the one thing that we might do to reduce suicide right now? I would argue that that thing is making connections. It sounds too simple, I know, but giving folks a reason for living, giving them purpose and meaning in their lives, giving them others to care for or to be cared for by, and giving them reasons for getting out of bed in the morning can be some of the most powerful intervention that we can offer. That's a hard thing to do, even though it sounds simple, okay? It's hard because it makes us bump up against our own comfort zone. And, what I would argue is that maybe the folks that we need to focus our interventions on are not those that are struggling per se, but rather the rest of us that are surrounding those individuals and have an opportunity to offer support. When we bump up against our comfort zone, we grow. And in that growth, we can help others, we can create community, and we can connect to those who are isolated. And that's how we're going to reduce suicide amongst veterans. We have to step past the stigma. We have to step past, being afraid that we might do or say something wrong. We have to step past the questions that are too hard to ask and ask them anyway. And we have to walk alongside those folks in their most difficult moments. And that requires a lot of vulnerability and a lot of willingness on all of our parts to do that. And so as I wrap up here and we move into asking for questions, what I would challenge each of you to do is to find that ability within yourself to extend a hand to somebody else who's in crisis, where it might be easier to just let it go, hope it resolves itself, and instead take that step forward and offer that support. Okay, I'm going to stop talking and see what questions we have here in the chat.
Larry, I'm going to jump in real quick.
Yeah.
Steve Chamberlain. For those who want to ask questions, recommend you just raise your hand or indicate that we have a pretty small group here, so you can do it verbally rather than via the chat. But Larry, that was fantastic. I really appreciate that, and you definitely gave some direction to us in terms of where we can go at the state level to be effective. And I'm wondering if you could perhaps in the next few days, if you've got some time, is just jot down some of the recommendations. I mean, one, for example, was to reach out to your Governor Challenge team and seeing that many are lacking any sort of a legislative champion, figure out what we can do at our level to codify that. Another one was the Onward Off program. Think concrete things like that I can then carry forward to our website. In addition to the video, maybe 4 or 5 specific things we can do right now. And you brought up some really good ideas, and I think every member of our group would really appreciate having those things in a succinct list. So if you could do that for us, just get that to me. That'd be great. And now
No problem.
I'll mute myself here, and whoever has the first question, or if you want to just signal and raise your hand, that'd be great.
Mark Olson, you have the question in the chat. Why don't you discuss that?
Yeah, so we'll start with Mark's question about the hyperbaric oxygen. Yeah, that's a great question. I actually used to work over on Joint Base Lewis McChord, and we had a couple of the big chambers right next to where we were in Old Madigan, if anybody's familiar with JBLM. So there's a couple of things that are worth discussing with this. One is, what's the mechanism, right? And with hyperbaric oxygen, I would ask, and I don't know that the science is there yet, to say, is it having an effect on conditions that ultimately lead to suicide, or is it having an effect on suicide directly? A lot of times with the hyperbaric oxygen, what we're seeing is that it helps with things like traumatic brain injury, where for a long, long time, we didn't have a good understanding of what happened to your brain when you're hit by a concussive blast, right? Let alone repeatedly. And so when we started really getting a handle on the kinds of injuries that were happening to service members' brains, how to address that, this became one topic that really was pretty fruitful and beneficial in terms of minimizing the degree of injury that occurred. Now, whether that ultimately translates into lower rates of suicide, we don't have the causal evidence yet to say that. So that's still going to be a work in progress. But again, kind of going back to a point I started with, if that had been truly effective at this point, after at least a decade of having these tanks active for folks, we probably wouldn't see the rate continuing to increase the way it has. Hopefully it would have leveled off, it would have decreased, and we just haven't measured that happening yet. So maybe we need to fine tune the intervention. Maybe we need more time to measure the outcomes. I don't know, but we can't draw that conclusion, scientifically right now.
So from my limited experience, I'm a career submariner, and we've used hyperbaric oxygen therapy for a long time for people with decompression and those kind of things. And I know that a lot of militaries are using it, a lot of sports teams are using it. And the advocacy that they're trying to do right now is to just get it as a prescribable by a doctor, viable option for people, because I think, to your point, why the suicide rates might not have gone down is that right now it's not covered. It's considered an alternative treatment. And if you want hyperbaric oxygen therapy, you have to pay for it out of pocket because it's not covered by the VA, by TRICARE Prime, TRICARE for Life, any of those kind of things. And I think that that's the main focus right now, is to try to make it a viable, authorized treatment option for people that would still have to be prescribed by a doctor or a medical professional in situations. What do you have any opinion on that?
I think that's a valid point. I hate talking about suicide and also talking about resources, because I'm first to say, like, throw whatever we can at folks if it's going to save that life. But there is a real resource related question, as it relates to this. And if you have a low cost, widely available intervention, there are a camp of folks who say, hey, why not do it just in case it is effective? And it doesn't offer any harms or any problems. That's a question that has to get addressed,
yeah,
I think, on a broader scale.
I came into this late in the game. There's 14 states that have passed either binding or non-binding resolutions along these lines. And I asked the question, just being the dumb nuke submariner that I am, saying, hey, this sounds like a viable option. And what they said, what I've been told, and again, I don't know that this to be true or not, is that it's a drug-free option. And so that the people that make money off of drugs don't like it, because they would right now, if you have PTSD or TBI, you have two solutions: do nothing or take drugs. I mean, in general terms, this would be a third viable drug-free option that seems to be a logical one, but apparently it's meeting a lot of headwinds because of the drug lobby and the people that make money off of drugs.
Yeah, and I can't speak to that per se, but it's an interesting question. Again, I think there's more science that has to be done to really know what the true effect of that intervention is, and at that point, then we can take it forward with things.
Thank you for your opinion.
You bet.
Shelley, you had your hands up.
Here in Colorado, we do have law on the book that provide a lot of money relatively to veteran mental health. This is just going on the books right now. It's through legislation. We got this money because there was an effort to provide an excise tax to ammunition and weapons ammunition.
What I got was you were asking about sort of lethal means safety as an intervention. And I heard I can see you're from Colorado. And so I'm not surprised to hear that at all coming from your state. But I'll hold for your question in the chat here, and then we can talk more about it.
Bill Ashton.
Doctor, appreciate you talking about everything here. I find that, and I'm going to use the word you didn't like to use, is on behalf of all of us, we should make the commitment to talk about this. This is something, as you said in the beginning, is a difficult thing to talk about. I'm sure you're aware of, and I hope everybody online is aware of, is a video. It's about 12 minutes long, done by Psych Armor for the VA. It's called SAVE. And it gets to the point, Doctor, what you had said. Difficult to talk about. A lot of times you'll hear people say, I didn't know what to say, or I wasn't trained in suicide prevention, so I just didn't know what to do. Well, I'll just be blunt. That's BS. You can, in fact, ask the question, do you intend to commit suicide? And you just have to be straightforward with them, and if they are, then you stay with that person until you can get help. And that would be dialing, the 1-800 number or the 988 number, whatever it may be. But I think the biggest problem, in my humble opinion, is the awareness. I think, and I've been out of the military for a number of years, but we would have this, general training, GMT, once a year, suicide prevention, and that was it. And nothing gets talked about until maybe somebody in your command commits suicide. And then it was too late to talk about it. I'm not even sure they talk about it in TAP. And so I think my opinion is it needs to be talked about more often. And when people are in TAP, it really has to be brought home there that there is help. Right when you walk out of the military, this warm handoff between the military and the VA, they need to know where to go. My motto is veterans don't know what veterans don't know, and it's not their fault, because we just don't, stay on that topic enough for them to do it. My last job was with the Department of Agriculture, and what a rude awakening was for me to find out how many veterans who are farmers who are committing suicide. It's a very high number. And a lot of it is because of, their crops ain't growing, they had flooding, and their answer to themselves is, my family would be better off if I was dead. And that's an unfortunate thing. So again, thank you very much for what you shared.
Yeah, and Bill, thank you for mentioning SAVE. So SAVE is VA's gatekeeper training, right? That's the training we want to get everybody educated on and trained on, so that if you encounter somebody in crisis, you know these 4 basic steps. And Bill did a great job with step 2, which is ask the question, right? Ask directly about suicide. Don't hem and haw. Don't try and soften the language. Just go in and ask the question, and then be validating and supportive, and stay with them and get them connection to help. Whether you were, I know Army trains in assist, other folks train in QPR. In Washington State, our State Department of Veteran Affairs has a program called Learn. They all cover the exact same steps, right? It's just how do we want to brand it? And they're pretty simple. And Bill, you did a great job with that. And you're absolutely right. We need to be able to have those conversations and ask those tough questions and be okay with whatever that person says. I also appreciate that you brought up TAP. So our governor's challenge here in Washington had that same concern. And so one of the things we did was negotiate with the folks at Joint Base Lewis McChord, and we got not a lot of time, about a half hour, but half hour at each TAP course to bring in a veteran with lived experience, somebody who had transitioned out, had, found themselves experiencing thoughts of suicide, reached out, got help, and now are powerful advocates for veterans. And they go into those TAP classes and they sit and they tell their stories and they say, hey, you're not going to connect with this. You're not going to feel it because you haven't lived it yet. But I'm telling you firsthand, here's what you need to know. Here's what you need to watch out for. And here's how where you can go to get help. And that's been really, really powerful in terms of getting folks to buy into, yeah, maybe I need to sign up for my healthcare benefits before I separate so that they're in place, so that on day one, I can walk over and see my primary care provider rather than, waiting for a problem to happen, then try to enroll and then wait 6 months, until that's complete and I have an appointment and then talk to somebody about it, right? You'll notice a theme here that early intervention, trying to tackle these things as soon as possible is part of that key to success.
Great. Robert.
Yeah, thank you. And thanks for bringing up the governor's challenge. I've been on a Maryland one for a while. And we started the crisis intercept mapping program here, which you're familiar with that.
I am.
And it was kind of a shock to us when we were asked, our county was asked to do it. We said, well, that's great. Thank you. No, we'll be the lead for the state, just out of curiosity. Why? I said, well, your county has the highest suicide rate in the state. Now, since that time in our crisis intercept mapping, we brought it down. But as Bill was just talking about that awareness and going, doing all that, and we have, I guess, maybe it's a unique problem here or not, but at our we've got Perry Point VA Medical Center is fairly close to our county, and they closed their urgent care center. They said all veterans now will just go to the local community and find out. And at a study, only 37% of our 19,000 veterans use the VA. So we came up with our little cards, and so kind of to ask the question: have and put these at the different places? Have you or a family member ever served in the military? So I thought it was interesting what you said about the 4 stages of crisis intercept mapping, that first contact. But what it seems like what you're talking about there too is even before that time. How do you get to people before that time and look at some of those things? One initiative that we started with the American Legion as part of Be the One is we have every September in Suicide Prevention Month, we have a We All Served hike, with the emphasis being on everyone serves and to bring people there. Because what we found was, I don't know, maybe you can talk to this. We found we have some of these resource fairs, you put things out, there's all these tables, people go by and they go, yeah, great. But when we had this and we had veterans and walk around, the veterans were talking to each other as they walk. We call it a hike. It's a 1.5 mile, nice, easy path, and people can do whatever, go. And we found the veterans talking to each other and talking about their situations. Then afterwards, having breakfast and talking about that. So it's interesting. What some of the things you're talking about there to see how we can incorporate that in there. The last thing is I run the crisis jam almost every week that they have for suicide prevention, as SAMHSA does. And lately there's been a lot of talk about and AI and suicide prevention. And some of it seems to me to be fairly scary that in some cases veterans are talking to an AI model and not to a real person as they go through their treatment. I don't know if you've had any experience or thoughts on that. That's my last point there.
So a couple of things. I love the ask the question. So ask the question is part of the governor's challenge, right? It's one of the core groups. And it's just to identify military members, right? And veterans, because not everybody identifies in that way. And so with 2/3 of veterans not using the VA for care, if they go into their local hospital or doctor's office, we want folks to be able to ask that question, because being a veteran carries a specific risk profile. And so getting that language out there, and your cards are great, I think is really important. I love your point about the outdoor stuff, whether it's a 1.5 mile hike or, here we have a ruck, and you start with a heavy pack, and every table you stop at, you take out a rock from that pack and you drop it on the table. And so your weight gets progressively lighter as the ruck goes on. And it's sort of symbolic of like, hey, when you share something, it gets a little lighter to carry, right? Whether it's that or I'm out here in Seattle, so we have a lot of fishing, a lot of camping activities. We have groups that go out into the woods. We have groups that build fishing poles and lures. like those things are socially acceptable amongst the veteran community, right? And so if you engage folks in those socially acceptable activities, and then you start having those real conversations, you get a lot farther than you do trying to bring them into the doctor's office and ask those questions where, it feels like, oh, maybe I'm getting evaluated here. Maybe there's something behind, what they're asking me. So I think those sort of real life experiences that can then facilitate those conversations are really important. In terms of the AI, like any tool, there are good and bad uses for it, right? So as a psychologist, am I going to get replaced by AI? And do I think that would be a good thing for my patients? I'm doubtful of that. I don't think that's going to happen, although there's lots of folks that think it might. Where does AI stand to benefit us? Well, there are things like practicing those conversations that Bill was talking about, or practicing conversations with, around firearm safety, where an AI chatbot can do a really, really good job of looking at your responses and determining if it fits within a specific protocol for intervention and coaching you back on like, oh, maybe you should have asked this way, or maybe you should have asked about this. So as a specific tool for training our clinicians on having very specific conversations, I think there's a lot of potential for AI. Whether, folks should be turning to those chatbots now and having those conversations, I don't think it's developed to that point, although it can look like it on the surface because they are so convincing. There still is a kind of a deeper level of language processing that has to happen before we're ready for that.
Well, we're sitting at the 9 o'clock hour. Let me see one new one here. Yeah. Jen Goodell from MOAA National says, great conversation, Dr. Pruitt. That interagency cooperation. Back to Bob Brown's comment about ask the question. That was a nationwide effort that the DSLO championed several years ago. Most of the states have that in legislation. In fact, I worked with Geraldine Valentino Smith in the Maryland legislature when I was the regional liaison for a DSLO to get that legislation passed. So, and it's a simple thing, and it goes back to one of your points about connecting various agencies at the local level, and that's any medical facility you walk in, you have to ask the question, have you served, or someone in your family served? It's a simple question, but it can lead to changing lives. One, two, it may change the support services that you might want to provide to that individual, as well as any therapy that might be interesting. It's, we've got, and that what really did was push them back to the VA to get them connected with the VA, because those are agencies that the VA has funding. You don't use state funding to provide those services. If you can get them connected with the VA, then they can talk to those other veterans that are having those issues. So certainly a wonderful conversation. I appreciate we appreciate you being here with us, Dr. Pruitt, and certainly the efforts you put into this. As I mentioned earlier, and if somebody may have come on late, we will have the transcript of this will be posted on our website probably by the end of the week. So if you missed any, didn't take copious notes, I'm sitting here, I've got 5 pages of notes, and I wasn't trying. And I knew right up front that we're going to get an AI version of this session that will have all that information in it. So I appreciate your time and effort. I could share, but those of you who are on right now, obviously, are getting our emails and our save the dates, and we appreciate your attendance and sharing that with the other members. I know some of you are probably in DC right now, preparing for AIA. Share this information with your colleagues that are knocking on doors in the next couple of days, talking to legislators. That's a great effort. I enjoyed it tremendously for 2 years when I was the president of Pennsylvania council chapters. So thank you much. Our next session will be in July. More to follow on that. And we'll obviously get a save the date out notice for that as well. I asked my colleagues, Rich and Steve, anything you have for wrapping up here?
Yeah. First, I want to thank Dr. Pruitt for his time and a great session. It was spot on, exactly what we were looking for to kick things off here. Um, and I appreciate the group for joining in on a non-traditional night and an extra session. Like I said, plan to see more on this topic. Hopefully, we can convince Dr. Pruitt to come back because I think that was really useful, and some other speakers as well. But spread the word. We will. Harold, Rich, and I will have Dr. Pruitt's the video up. Yeah, the specifics when Dr. Pruitt's able to get them to us, some of the specific things that can be done right now and how to do them, and a summary of this session, and spread the word to other state legislative exchange forum members who weren't able to make it tonight. We know it was a busy night, so again, we really appreciate you taking the time to do this. But I'd like to, drive some traffic to the website and get some other people to take a look at the video that we made from tonight because I think it's really beneficial, and I don't think there's anyone who can argue this isn't a topic of the highest priority. And I really do appreciate. I'm not one for language nuance sometimes, but I really took away a lot from the took one's life from or suicide took one's life as opposed to committing suicide. I never really thought of it that way, but it changes the perspective. It shifts the paradigm in a way that really hit me hard. So thank you for that, Dr. Pruitt. And that's all I have. I just appreciate everyone for taking the time.
Well, enjoy the rest of your evening, and certainly we look forward to seeing those members of the forum in July.